women's health equity is one of the fastest growing areas of healthcare, but it still faces some big challenges. Women tend to live longer than men, but they spend more years in poorer health and often have worse outcomes for many conditions. And this happens even though women play a huge role in making healthcare decisions and have growing economic power. So why is this still the case? What can we do to fix the gaps in research, policies and healthcare? And how can we work together to help make real change happen? This episode was recorded after a roundtable event hosted by THT Plus partners Kearney and UN Women Australia. They brought together some amazing people who care deeply about improving women's health equity. I had the chance to speak to a few of them after the event to dive more into the topic. And in this episode we talk about why women's health equity needs a fresh approach, how can we tackle gender bias in healthcare and research, and the benefits of investing in women's health for everyone. Collaboration starts with a conversation, Team HealthTech. Let's make it happen.
Simone Clarke, Chief Executive Officer for UN Women in Australia.
Thanks, Simone.
Stephanie Allen, Global Health Leader for Kearney.
It's great to have you both here in this scenic spot, a little bit windy, but it adds to the ambience, right? But I'd love to learn a little bit more about you both and the work you're doing, especially coming off the back of the roundtable event, which we're going to dive into in a bit. But Simone, did you want to start?
Sure. So just to give you a bit of context around the work that UN Women does, both globally and in Australia, we're focused on accelerating SDG 5. Effectively, that is the goal that the globe signed up to, that by 2030 we'd reach gender equality, and unfortunately we are a long way from achieving that. But part of that in the SDGs is the interconnection between other SDGs, and another really important one is SDG 3, which focuses on the health and well-being of women, people, communities globally, and it's one of the things we're here to have a bit more of a conversation about today.
Yeah, excellent. And I know that ties in with the work that Kearney does as well, right?
Yeah, thanks, Peter. So we have a multi-year global investment actually leaning into what we call this Women's Health Initiative. And it really builds on the back of what Simone's been talking about, which is the time is now right to actually really start to address why women have poorer health outcomes, and what is the opportunity to actually make a difference in that space.
And so, this roundtable event, it was a bringing together of a lot of different perspectives on this topic. Tell me a bit more about what you took from that event.
I think one of the key things and the key takeaways for me, which will probably be quite surprising to most people listening to our conversation today, is the fact that there is so much underinvestment in women's health, and yet the size and the scope and the growth of the market in women's health is expected to reach about 5.5 billion by 2030. So when you look at that, and when you consider that half of the world's population are women, when we're having conversations around the table about the fact that research, data, investment in women's health is not where it really should be. And so again, unfortunately, what we're seeing in the women's health space in particular is exactly those same gender inequalities that are faced across the board, whether it's health, whether it's in education, whether it's in economic empowerment. Women are disproportionately marginalised from full participation. And we know that if women are healthy, if they're in charge of their own health decision making and have the financial resources to invest in their own health, that we will have far better, far more productive communities and societies. So it's really important that we start to focus more on women's health and the importance of it. And I think that's where the roundtable and certainly Kearney's involvement has been so incredible to really shine a light on the work that still needs to be done.
Yeah, thanks, Simone. So I think the really interesting thing about women's health is that people don't realise how powerful women are in healthcare decisions and healthcare expenditure. So when we do research, it doesn't matter where you are in the world, whether you're a woman in Pakistan or a woman in the US or a woman in Norway, about 86% of all healthcare expenditure is directed by the middle-aged woman in the family. So whether she's directing the expenditure on behalf of her parents or her in-laws or her husband, go and get your prostate checked, or her kids, she is the one that is actually making those decisions in terms of who is accessing healthcare and how. And we did some really interesting work here in Australia, and it also showed that in 72% of cases, women make the decisions around the health policy that we're going to have. So are we going to go for Bupa or Medibank or HBF? The actual policy itself, which policy do I want to protect my family? And also direct private healthcare. And then last but by no means least, they make 97% of all decisions around grocery shopping. So the food that we eat, that we know is fundamental to health and household expenditure. So as Simone says, not only have we underinvested in women's health, but we also haven't recognised what a powerful agent they are in the way that the healthcare system works and the volume of activity that actually gets created.
I think one of the other really interesting things that came out in the roundtable, which again seems like a bit of a no-brainer, is the fact that fundamentally women's and men's bodies are biologically different. And yet we apply the same research, the same data to a large extent to really inform the solutions. So I think that's where the underrepresentation in women's health also needs to be addressed, because it's really important that, surprise, surprise, women's bodies are different, and so they require different solutions, different interventions and different support. So again, we're seeing a whole lot of work being done around things like menopause in the workplace, the impact that's having on women. So I think women's health, again, has a very gendered, unsurprisingly, lens to it that we really need to face into.
And again, just building on that, it wasn't until the 1990s that women actually got involved, or females got involved in clinical trials. So we would test drugs on mice and we would exclude female mice because they had a hormone cycle, not actually thinking beyond that and thinking, well, we need this drug to work with females that make up half the population that also have a hormone cycle. So you find that, about women experience adverse drug events 1.5 to 1.7 times more than men. And that's because the drugs often haven't been tested on women before they actually get registered onto the market and are available for use. So there's a real discrepancy between, as Simone said, even how clinical trials and research has impacted women. We've got stents that don't fit female hearts. We've got plates in arms that actually are too long for the female arm. There's all sorts of things where we need to play catch up in terms of making medicine actually think about and putting women first.
So thank you both. And so UN Women Australia, what role do they play in trying to address some of these issues then?
So within the UN system, UN Women is one of the agencies that is dedicated to achieving gender equality. And here in Australia, UN Women Australia is focused on raising advocacy and awareness and funds for our much needed programs around things like women's health, education, equality and protection in various different ways, shapes and forms. So what does that look like here? It's really looking at things like, unsurprisingly, things like domestic violence and the impact that has not only on women's health, but also on communities, on financial and economic output. We also look at women in emergencies. We know that when emergency strikes, women die at a higher rate than men do, simply because they are usually staying behind to look after families and children. We also look at economic empowerment here in Australia and ensuring that every woman has access to their own finances and understanding of how they work, because with that financial independence also comes a sense of power, but also ability to determine their own outcomes. So there are so many aspects of gender equality that really we need to lift our game on here in Australia. We have a national women's strategy that was just launched in March of this year, and it's a really important strategy which looks at all the key biases and indicators that are impacting women here in this country. And if we look at First Nations women in particular, and we look at their health statistics, their maternal mortality is almost 3 times higher than their non-Indigenous counterparts. And we know that they have a significantly higher, I think it's something in the vicinity of 17 times higher mortality rate. So here in Australia, we've got a lot to do. And then if we look at reproductive health in this country, again, there's still a lot of work we need to be doing in that space, around education, around understanding. And I think if we look at the geopolitical landscape at the moment, we'll know that reproductive health and women's rights in that space are incredibly important to half the world's population.
Well, I mean, this is reflecting on, this scene, and it's one in a healthcare, in the industry of healthcare, which is all about helping people and doing good at the heart of all of it. Everything is, I think you used the term no-brainer as well. And it feels like on the surface, obvious things that we should just be getting right. Like there's a lot to it under the surface there. It's I'm thinking, what can healthcare organizations do to be able to start shifting the needle and actually, do what we say or do what we mean when it comes to improving that gap in health equity for women?
So I think it goes back to basically the gender bias that women face in all walks of life, whether it's in the workplace, whether it's our health, whether it's the way that we are treated, whether it's cultural behaviours. The challenge with the change that we're facing is some 200 or more years of misogyny and gender bias, which won't be addressed in my lifetime, unfortunately. I'm hoping that perhaps for my daughters, they will face into a better, more proactive life where they have more control over their decisions and what happens to them and for them. But we're starting to see those changes come in. I think that's really important. Trying to push the envelope on women in leadership, more women in leadership, because with leadership comes power. With that power comes an ability to make decisions. And if we look around corporate Australia, for example, on its most broadest sense, the number and underrepresentation of women in CEO companies as CEOs in the top ASX 300 is less than 20%. So when you add that up, the complementarity of women and men and how we lead is being undersold. And really, if we bring more women into that space, we will get more balanced decisions, not better decisions, but we will get a complementarity of leadership and decision-making that this country desperately needs. And I think we've seen it in the recent, or not so recent, elections where we have a lot more women holding seats in the Australian government. And that's making for a more lively discourse around the things that need to change in Australia and beyond for women more broadly. And as we spoke about earlier, we're 50% or more of the population, so it beggars belief that we don't have 50% of the voice.
Yeah. And what about in healthcare specifically?
So there's a whole variety of things that you can do in healthcare, but it really starts, as Simone says, around awareness raising. So when we had our women's health dinner, we had some really senior board chairs. We had some investment banks. We had some private equity firms. And it was really interesting because one of the board chairs came up to me afterwards and he said, I rarely get to go to an event where I'm really challenged. And he said, but you've really challenged my thinking about how the companies that I am a chairperson of are really responding to women's health. And he's a chair of a aged care company, a big hospital, both public and private, and also a global cancer treatment company. And he said, at my next board meeting, I'm specifically going to ask that question of the executives. What are we actually doing? And how do we know what we're doing? So are we collecting the data? Are we actually finding the insights to work out what our products and services and even the experience that we offer, is that appropriate and are we meeting women's needs? And I think that that's actually where it needs to really start. But, we are starting to see this enormous female consumer healthcare market burgeoning globally and here in Australia. And so one of the things that I like to talk about is, there's a really important moral and social reason why we need to address women's health. And Simone has laid that out with absolute clarity today. But you don't necessarily get change because there's an immoral and a social issue. And we see that with sustainability. It is too expensive to move from this type of fuel to that type of fuel or to make those changes. Whereas with women's health, not only is the moral and social imperative, but there's a huge market. So there's a huge commercial opportunity for those organisations that are prepared to face into it. So we're working with some of our big healthcare clients and getting them to think about, are the products and services that they currently offer manufactured in the right way, sold in the right way, have adaptations in the right way? And they're finding this whole new market and this whole new commercial reality by actually putting women into their business model.
Well, that's something, isn't it? It's all about framing sometimes, I guess. And it's such a great point that even though it's the right thing to do and the things that we should be doing, that'll empower a lot of organisations and individuals to be able to then align it with all of those financial incentives that also drive decisions at board level and other areas too. If we can demonstrate that value there, then there's a lot of opportunity that exists. And so, Simone, earlier you mentioned the SDGs that UN Women is working on directly. Tell me a little bit more about what's driving that change. 2030 doesn't sound that far. A while ago it sounded really far away. It's not that far away now.
No, unfortunately it's not, and the deadlines are looming and the progress is slow. I think the key thing to think about when you look at the SDGs, they are global goals that we all signed up to, that 193 or more member states signed up to, said this is what we want to achieve by 2030. The so what of that is that we are far from achieving gender equality, and when we look at SDG 5, which is around health and well-being, we're still a long, long way from that when you look globally, and obviously health rates and investments vary country to country. But I think the critical thing in all of this, and particularly as it relates to gender equality, is that we know that if we don't achieve gender equality, none of the other 17 SDGs will be achieved. So when people say, why is it important? That's the heart of why gender equality is so important. Because if we don't take a gendered lens to the inequalities that are currently facing us, we will never be able to achieve things like addressing poverty, alleviating hunger, and those other large, big, hairy goals that we all set for ourselves some time ago. So I'm hoping with more action, with more focus, and there are a lot of players. We don't do this alone. There are literally governments, organisations, groups like Kearney who are working in specific areas to really drive change, particularly around women's health. And I think that's absolutely pivotal because we know that with healthier societies, you have better outcomes. And I think that's really what we all want, a safer, better place for us all to live with fundamentally our health and well-being at the core.
Yeah. Well, if we're going to drive all the other SDGs, then it feels like a ticket to play, doesn't it?
It does, yeah.
Getting that one right. So, and Steph, then tell me, outline for me to close it out, the things that Kearney are doing to be able to really drive action in this space.
Yeah, thanks, Peter. So, we could write white papers till the cows come home and they'd make absolutely no difference. So we presented, basically, we could write white papers, but it would make absolutely no difference. So one of the things that Kearney prides itself on is actually action. So how do we mobilize? How do we become the catalyst for real action and real change? At Davos last year, we had an open letter where we invited essentially the healthcare and life sciences and government and policy community to come together to say, we are actually going to make changes in our businesses to actually address this issue. And thankfully, we've done really well in that regard. So we've now got over 270 global organizations that have signed up to the open letter. They're big pharma, med tech, healthcare, technology, private equity firms, investment banks, lots of community groups, and then the policy think tanks. So like, Bill and Melinda Gates, UN Women, and others. So we've got this really important melting pot of, mobilization for change. And there's a community that are constantly talking to each other, sharing ideas, and actually taking some really important action. So again, looking at, I heard the other day that now research grants, even here in Australia, you won't be awarded a research grant unless you say that you're going to do the research on women as well as men as healthcare participants. I'm working for a big medtech device company where there's a huge underdiagnosis for women, and they're now seeking to really step into that space and address that market. So it's a real mobilization for action, and that's what we're most proud of, and that's what we're continuing to invest behind.
Hi, I'm Kathryn Evans. I'm the Managing Director for BioMarin here in Australia. We're a company that develops medicines for rare genetic disorders to transform patients' lives.
Excellent. Thank you, Kathryn. And so one of the attendees for the roundtable that Kearney recently held, tell me a little bit about the your takeaways that you walked away from that session with.
So my research background actually is women in leadership. And I've looked over many years at how Australia's been performing on the World Economic Forum Gender Parity Index. And actually, when you look at health and survival, that's an area where Australia actually performs pretty well. And at 0.96 out of 1, we're pretty close to parity. So my focus really has been on other economic factors such as political empowerment and economic participation of women. So I was really surprised actually when the presentation looked at some of the inequities in healthcare, that while women may live 5 years longer than men in Australia, they're actually living in poor health, being misdiagnosed or not having their health concerns taken seriously. So that was a bit of an eye-opener for me, really.
And tell me a little bit more about the economic impact. You've mentioned that's tied in with the work you're doing in the research. On that point around the access to quality healthcare services for women, like what is that economic impact then when I guess we look at the numbers?
Well, I suppose if you've got women who are living with chronic health concerns and not having the same access to good healthcare, then there's an impact on productivity. So all of these things are linked. It's not, health does not live in isolation from anything else. And I think in the industry that I work in, which is the pharmaceutical industry, I've long held the view that there is a big disparity between men and women in the way that our government and our health funding system works. So, for example, a man with erectile dysfunction can go along to their GP, get a script and receive Viagra, right? However, women who want access to modern contraceptive products are paying for them out of their own pocket. And then when they reach menopause, they don't have access to all of the modern menopausal hormone treatments that are available. So, just in that simple way, why is that? Why is that men's health concerns are funded and taken care of, and women seem to be not taken as seriously?
Yeah. You asked why is that? I don't think there's a simple answer to that, but you've obviously been focused on this for quite some time. How do we start unpacking that really hard question?
Well, I think that it does actually have similarities to the research that I did on women in leadership, that there's almost a belief that, hey, everything's fixed, men and women have equal opportunities, and it's really down to choice. And that's not the case. What I found through my research is that there is a significant amount of unconscious bias. It's not intentional on the most part, but it does have a profound impact when you look at leadership of the proportion of men and women reaching the top. And we know that women in Australia have been educated in higher numbers with higher degrees for more than 3 decades now. And yet we're still seeing that men reach those top positions, CEO, senior leadership level, in much greater numbers. And it's not a question of ambition. So the driving factor is unconscious bias. And I think when we look at the healthcare sector, that also pervades everything we do. And we need to think more intentionally about it if we're going to address that underlying bias.
Yeah, well, if I think about my quite limited understanding of, say, the concept of unconscious bias, by definition, as I understand, it's kind of like you don't know that you're doing it. So that intentionality that you mentioned just then sounds really important, but that's a lot of, what is that then? Is that awareness building? Is that tying to incentives? Are there different initiatives that we can kind of be utilising to start raising more consciousness to this bias?
Look, I think it's all of that, actually. First of all, you've got to acknowledge that there's a problem, not pretend that we've fixed everything, nothing to see here. And that's where data is really important. So the Women's Gender Equality Agency, for example, publish data every year from employers with more than 100 employees. And so the first starting point is the data. Because I'm a business person at heart, I truly believe what gets measured gets managed. So if you measure it, and then you need to be intentional about putting targets in place to proactively address it. And that's the intentionality piece. And if you do that, it will happen. And we've certainly seen that in the public sector, where there have been through all the state and federal government levels have been long-held targets, and with targets go proactive programs that help to support addressing that imbalance, and they work. And we've seen the gender balance actually happen at those senior levels when we do that. So I think you can apply those same principles to these inequities in health. And it's great that people like Jed Kearney are looking at the issue of getting gender equality in women's healthcare. through the programs that she's supporting at the national level. So having that intentionality, we will start to see change. But if we pretend everything's fine, nothing to see here, nothing will change.
I'm James Elliott. I'm the academic director of the Kolling Institute, and the Kolling Institute is the oldest medical research institute in New South Wales. We're about 104 years old now, or we are 104 years old. We're a unique medical research institute that we're supported by a joint venture partnership between the University of Sydney and the Northern Sydney Local Health District. And at the moment, and for many years, we're a biomedical research institute, but we do have a nice mixture of clinical-based research scientists and basic scientists, meaning in the laboratory. We have 4 current areas of focused research, and that's expertise in cardiovascular and renal disorders, kidney disease, neuroscience and pain, musculoskeletal conditions like osteoarthritis, low back pain, neck pain, etc., and also cancers and many different tumor streams that we have really some of the most well-respected researchers in the world.
And so that's great context. And so what brought you to the Kearney Roundtable event that just recently occurred?
Well, probably a privilege, really. I was very fortunate to be invited, and obviously representing the Kolling Institute and our 2 joint venture partners, and was so delighted to receive that invitation because it was a very enlightening evening for me. I have been very fortunate to study traumatic injuries for the past 25 years, and these are traumatic injuries that, say, come to our hospitals after a motor vehicle collision, a slip and fall at work, or in some cases, unfortunately, domestic violence and sexual assault, which we know all too well impacts women at an alarming rate.
And so we're learning through the roundtable event and through these discussions today in this episode, there's been this, there's definitely not a new issue in terms of underrepresentation of women in healthcare and any part of the world. How do we, we've identified the issue, at least for us here in this conversation now. There's more awareness to be done, but then also how do we tie in some action, what can we start to do to start to address what's been caused by all of this historical underrepresentation?
Yeah, it's a great question. Well, it's more than speaking about it. Yeah. It's actually getting involved. And I think what I took away from that evening at Kearney, of the many things I took away, one was that I want to get the 800-pound gorilla here in front of us right now. I'm a 55-year-old Caucasian male, and I don't think I could put my hand on my heart that I've ever experienced sexism in my career. I've worked hard like you and like everybody else to get to where I am, but I talk to my colleagues who are not men, who share with me their stories and their upward trajectory in the academic sector and certainly business world has not been without sexism. But I think what's really great about that is that none of my women colleagues or friends, I don't hear them asking me to apologize for my position. What I hear them saying is, join us, become involved. And I think that's the most important thing for us men to realize. While we may be the problem, we're also very much part of the solution.
Yeah.
And that's kind of one of the many things I took away from the evening.
Yeah. The work that you do and happening at Kolling as well is, very much tied to the research side of things. And sometimes research can be quite distant towards, action, but you need that foundation and that work to underpin it all. What do you think the role is of research in this space to be able to then link into some of these things that need to be done?
Sure. I'm immediately reminded of the work done by Teresa Woodruff, who's a professor at Northwestern University. For years, Teresa had been working with the NIH, National Institutes of Health, the funding body in America, to ensure that every proposal that came to the NIH for consideration of funding had sex as a biological variable in its statistical design. And now that's policy. Whether you're studying mice or studying people who've had a trauma or a disease, you have to have sex as a biological variable in your design or it's sent back to you. And I think we are starting to see that. Canada does that as well. We have to embed that into our statistical designs, into our analyses, into our studies, whether it's animal models or human models. And it's not, and until we do that, we're not going to see a big change in that. Now, I'm heartened by the fact that Australia is actually going that way as well. I'm not aware of a policy just yet, but I am aware that lots of people are talking about it and incorporating that into their research designs.
Yeah. We've got the right awareness around the problem and a lot of conversations that have started, which is great, but we've got to tie it in with that action now. That out and do it.
Yeah, I don't think we can just sit around and talk about it anymore. You have to actually get involved and do it. We can't wait for someone else to do it.
Yeah. And so for those that are listening, think about, well, what can I do? Or if there's the examples that you could provide of ways to participate. Is there anything that's caught your eye?
Yeah, thanks, Pete. That's great. I realize that can't do everything. We probably should pick one or two things and do it really well. And so an example of that is at the Kolling Institute. We're very proud to partner with Franklin Women's. Franklin Women's is run by Dr. Melina Georgasakis, and she's great. And she has, in a very passionate way, has designed Franklin Women's. And Franklin Women's is a social enterprise that has at its core mission to create a healthcare and medical sector where women come to thrive. And it's all about this thing. If you look at the trajectories of our career in academic and health and medicine, men and women start out pretty equally, but there's this scissor point where men just keep going upwards and women, maybe they decide to have a family, maybe they decide to take some time off. But for obvious reasons, they don't have the same career pathway as men typically. So we partner with Franklin Women's. They provide us the opportunity to send 3 of our early career, mid-career women scientists to get the training that they need to learn how to access resources to help their career along. And the nice thing about it is that it's men and women working together in the mentoring and mentee space. So it is a great program that we very much enjoyed partnering with. And so that's an example of getting involved.
Yeah.
Pick something and pick it and do it really well.
I'm Professor Bronwyn Graham. I'm the Director of the Centre for Sex and Gender Equity in Health and Medicine, which is based at the George Institute for Global Health.
Yes. So we've done we've had episodes where we've featured some conversations tied in with the George in the past. But tell me a little bit more about the work you're doing in your area.
So the centre is aiming to reduce the sex and gender-based inequities in healthcare. And the way that we want to do that is by making sure that sex and gender are routine considerations at every stage of the health and medical pipeline. So that's from the very basic fundamental research that we're conducting in cells all the way through to the clinical trials, the development of the med tech and innovations, and the way that we're treating people when we see them in healthcare services.
Yeah, excellent. And so you attended the Kearney roundtable that happened recently. Tell me a little bit about the takeaways you've taken from that session.
Well, the first takeaway that I got from the roundtable was the enormous appetite that there is for change amongst people for whom awareness of these biases in healthcare is very new to them. So it's really, as somebody whose bread and butter is trying to educate people about these biases and work out where there are levers for change, to see that process of people being informed about the nature of these biases and then thinking about what they can do within their own spheres of influence, whether that's people who are developing statistics on the health of Australians or people who are involved in providing health insurance. It's wonderful to see people excited about that change and also thinking about, do we have a sex and gender policy in our workforce? Could we introduce one?
Yeah, got you. Well, that's it. Sometimes when your world is so focused on this, and when it extends out broader, particularly in an area like healthcare too, where intrinsic in the nature of healthcare is the care for people and inclusion and whatnot. But the inherent throughout all of it, historically, as I'm learning, there's these biases that are baked into how we do things. So and that's a tricky thing to kind of unbake. How do we start to unpack and shift the needle towards undoing some of these, say, more systemic biases that exist within everything?
I think that the first step is becoming aware of where these biases exist, right? And as you're saying, they exist along every step of the pipeline. So historically, we've assumed that the male body, the adult male body, I should say, is the default.
Yeah.
And that all knowledge that comes from the male body can be translated, applied to everybody else. And we now know that that's just not the case. Of course, we're aware that there are female-specific medical conditions that we need to attend to, like endometriosis and ovarian cancer. But actually, sex and gender influences on these, on health are so pervasive and impact every single health condition, even those that everybody experiences, like, for instance, asthma, Asthma symptoms fluctuate over the menstrual cycle in women, whereas the different rates of lung development in boys changes their propensity to develop asthma. So we have to be considering sex and gender at every stage. And the way that we do that is to implement policy that asks people to think about how might sex and gender impact the questions that you're asking, the outcome measures that you need to use, the interventions that you're using to treat these conditions. So we have that top-down policy, but then we also need people with the capacity to implement that policy effectively, right? So we need education. We need researchers to understand why sex and gender matter. We need healthcare providers to know how sex and gender might change the treatments that they're delivering. And that comes down to introducing sex and gender as core competencies in our education system.
Yeah, I'm getting the sense that, throughout these discussions, even just in this episode, that there's not one particular lever that needs to be pulled to be able to kind of shift the needle towards where we need to go. I think that you do need the research backing behind it to be able to then really understand the problem, the education, as you pointed out, but then also the rules, the policy, the top-down approach to be able to kind of align those incentives and even the commercial elements to come through to be able to look at really the economic impact of bringing this focus on the need for better gender equity and equality. Easier said than done, and elements. But the key takeaway I hear from you is that to be able to really put in place some of the policy at a top-down level, you need to also enable the education awareness of people to be able to align with them.
Exactly. In an ideal world, we would not require any policy for these changes to take place. But of course, the beauty of policy is that it first of all brings awareness, but secondly, it just puts in place the best practice principles for how does one actually adequately consider sex and gender when it comes to healthcare. But policy is never going to succeed if you don't have that capacity and that education. And so I think working from the top down and bottom up approach, we're going to meet somewhere in the middle and hopefully see these changes emerge.
Yeah.
I'm Dr. Elizabeth Shaw. I'm a structural and interventional cardiologist, so I look after heart health and cardiovascular disease, and I also operate. So if someone comes in with an acute heart attack, for example, I'll open up their arteries and put in a stent for them straight away at any time of day or night. And I also do TAVIs, which are transcatheter aortic valve implantations, where we put in a new aortic valve for patients that have severe restriction of opening of their valves.
Wow, amazing.
I'm also the Director of Cardiology at the SAN and Director of Shaw Cardiology as well.
Thank you for that. And so, you were at the Kearney Roundtable event recently. Tell me a bit about your involvement. What brought you to that event? What interests you and maybe what you took away from it?
Well, being a female cardiologist, I have always had an interest in women's heart health, in particular cardiovascular disease. And I was really privileged to be part of this powerhouse roundtable discussion that we had that talked about women's health, not just cardiovascular, but in all areas, and global issues were discussed as well. And it was great to hear some of the other health areas, like mental health being discussed and breast cancer, for example. Australia actually leads the in breast cancer awareness and outcomes, which is great to hear. Cardiovascular disease is quite lagging behind. And, we discussed the different outcomes for women compared to men in cardiovascular disease.
Yeah. Well, that's interesting because, from my, if you're taking a broad brush approach to having a conversation about women's health, my mind immediately goes to it's super important we cover off fertility, menopause, mental health, but cardiovascular health, some people might just be mistaken to think, cardiovascular health is cardiovascular health. But you mentioned there's some disparities between men and women. Tell me more about
that. Yeah, no, definitely. I mean, we know that women live longer than men, but they actually live with higher burden of disease. And so that really needs to be addressed. In particular, for example, cardiovascular disease, women present differently to men from their heart attacks. They don't always have the typical chest pain, for example, that men may present with. And sometimes it's missed, even in the community, even in the hospital by doctors as well. And so it's really important to educate everyone with regards to the different presentations and in particular the general population to know that when they come in with fatigue or shortness of breath, that might actually be something wrong with their heart and to go get their heart health checked.
Well, that impacts all the stakeholders, right? I guess, did you mention even at a clinical level? So clinicians, a patient might present to the GP or go to a specialist. Do you think that we've got enough focus and attention on being able to differentiate what cardiovascular health is depending on gender?
Look, I think we'd certainly need more trials. Most of the trials that we've done so far are predominantly male patients, and so we need more information on female patients. For example, we had a trial done in Australia, an Australian data that looked at patients with STEMIs, which are ST elevation myocardial infarction, so acute heart attacks where they have a complete occlusion of their heart arteries. And we found that these patients that presented to hospital later were less likely to be offered revascularization with stents or a bypass, for example, and has worse health outcomes compared to their male counterparts. That's really scary in Australia in our day and age. We really would think that once you get to a hospital, treatment would be the same. But even within hospitals, there's disparities in women and men in their cardiovascular outcomes from acute heart attacks.
And so I think about the what to do about it then. You touched on the need for more research, and there's a big role for even just awareness. So, at the starting point, are they the two kind of key things that we need to do to be able to start driving better outcomes, or perhaps closing the gap in the disparities in terms of outcomes for cardiovascular health between men and women?
Yeah, definitely. Research is really key because when clinical trials as well, not just basic science trials, but also clinical trials to look at how women respond differently. Women are not the same as men in terms of how our bodies respond to drugs and treatments, and so those trials are definitely important. But also I think educating the healthcare providers and the general population. For example, women that have had gestational diabetes or preeclampsia or high blood pressure during pregnancy are more likely, up to 4 times more likely to develop cardiovascular disease in the next 5 to 15 years. And so a lot of times GPs don't even ask patients those questions when they come in for their health check. I know many of my colleagues, we've had this discussion where they go and they're not asked because GPs are really time pressured and to get through so many questions and things they need to ask and address. But I think it's really important that when assessing a patient's cardiovascular health, that those issues are addressed. I'm actually working with a company, a medical education company online called Med that goes through and helps to deliver online education for healthcare professionals, not just GPs, but also other specialties and cardiologists too. I'm sure not all cardiologists ask those questions, and it's really important to then, because if they have those risk factors, then that needs to be accounted for and targeted, and we need to be stricter with their cholesterol and their blood pressure control than their counterparts potentially.
Yeah. And finally, any other final thoughts or things that you'd hope that, let's say perhaps that would happen within this health ecosystem to be able to raise that awareness or improve those outcomes for cardiovascular health for women?
I think it's really important for trying to reach gender parity in terms of the workforce. The Ottawa Consensus say that our health workforce should really reflect the population that we treat. And at the moment, it's heavily male-predominated specialty, cardiology, and especially in particular interventional cardiology. So I'm part of groups to try and, be role models and mentors for trainees coming through to encourage them to do cardiology and impact patients' health from that point of view.
So my name is Roopa Mehta, and I'm a consultant manager at Kearney, a management consulting firm. My previous education is as a medical doctor, and then I did an MBA and have been at Kearney for over 10 years.
Excellent. Thank you, Roopa. And it's been great to have this opportunity to speak to such a diverse, interesting, intelligent group of people that all attended the roundtable event that Kearney held recently. Actually, firstly, for you, what were some of the key takeaways and things you'd want to highlight from that bringing together of great minds?
Well, I think, yes, it was lovely to have such a diverse group of people from industry, from research, from the clinical specialty. So we had such a diverse group of people, and I think it was great. People have made connections with each other, and so we've enabled that, which I think has been really great. So there's some research projects going on as a result of our introduction. So that's really great. And I think it was the ability to share some of our research and some of our findings, which I think the feedback was that people found interesting. Even though they are working in these areas, they haven't really known, for example, that women make 80% of the decision making in healthcare. So it's really important to understand women and what their unmet needs are. So I think the feedback was very much so that the data that we provided was really, really interesting. And in terms of the market is such a large market, women's health, and it's growing. And it's anticipated to be about $5.5 billion in 2030. So femtech is an area that's really driving that growth. And so that's a really important part of women's health.
Yeah. And what's come out from the conversations that I've had today has been, there's various levers to pull or perspectives to take on looking at perhaps bridging that gap or improving health equity and equality for women in particular. We can look at it through the lens of research. We can look at it through the lens of education and awareness. There's the commercial opportunities that exist, and there are others that are there too. And we heard about a few specific examples of it. But I'd love to hear from your side, I guess, where is kind of the investment funds going and where's the money going in terms of where those future opportunities might be when we're looking at women's health in particular?
Yeah, so that's a really important area. So our research has looked at the investment. We've looked at it both in Australia and in Europe, and it's shown quite similar insights. And it's also shown that there is a real opportunity for innovation. And, to get long-term, large-scale change, you need innovation. So I think that's really, really important. So, if women attend healthcare more frequently than men do, women are greater participation in preventative health, and they, as I mentioned, make 80% of the healthcare decisions on behalf of their families. So you've got and then in a environment where you've got a large and growing market, that is a ripe for innovation and for investment. So we looked at private equity and we looked at venture capital investment, and we found that that investment has grown in women's health by about 300%. So that's a huge increase in investment, and that compares to health in general, which is about 28%. So there's definitely interest in the area. And a lot of it is being driven by women. Women make up 2/3 of the founders of these health startups. So, we know that when women lead companies, they actually do better and they perform better. So that's a great positive. So what we found, though, when we look at the different disease types that investments are made in, you can divide it up into 3 areas. So you've got women-specific conditions, so fertility, for example. But women's health doesn't end at fertility, although we tend to stop talking about women's health when we stop talking about fertility. But there are 2 other areas which we can talk about. One is that where health disproportionately affects women. And examples of that are autoimmune conditions, where women are 4 times as likely as men to have an autoimmune condition. And then there's conditions where women react differently to certain conditions compared to men. And a couple of examples there are mental health and cardiovascular disease. So we present differently, for example, when we're having a heart attack to men. And that's not widely known, but that, and these 2 conditions are the number 1 and number 2 killers of women. Dementia and cardiovascular disease are the number 1 and number 2 killers for women in Australia.
Yeah, right. No, and that came up in conversations in this episode as well too. Is that quite often we see when the focus is on women's health, which is great. We focus on those core elements of fertility, menopause, and things that we kind of immediately associate the two. But tell me more about the segmenting into different ways of thinking about.
Yeah, so we found that the investment, 70% of the investment is in reproductive health.
Right.
So all the money is going into there. And what we want to do is increase the awareness that there is a huge opportunity and a big white space available for investment in these other areas, which also, predominantly affect women differently and disproportionately to men. So there lies the opportunity, I guess, for investors. There's another area that our research looked at, which was in terms of burden of disease. And really, if we want to make a great economic impact, and there are figures thrown around the huge economic impact by looking after women's health to our economy, and it's something like $128 billion a year in Australia. So a huge economic impact. Well, then we need to be addressing some of these other conditions that affect women and that have a high burden of disease. So again, cardiovascular disease and mental health are right at the top, where they have a huge impact economically in terms of burden of disease, and that's measured by DALYs, but they have minimal investment in those conditions. So again, take endometriosis. There's quite a lot of talk about endometriosis at the moment, and it affects 1 in 9 women, or between 1 in 7, 1 in 9 women in Australia. It's a very painful, debilitating condition, but we don't have any diagnosis. We don't have a diagnosis for a way to diagnose endometriosis, and we don't have many treatment options. So, that leads back to investment as well as research, of course. But if we could invest more and find solutions for this condition, then we potentially would have a benefit in terms of economic impact.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.